Hey everybody, Dr. Becker. We are going to get started on Chapter 1, Introduction to our textbook, and we're going to cover the role of the advanced practice nurse practitioner as being a prescriber. We have our objectives listed here. I'm going to skip through these introduction slides here to jump right into number 1 is roles and responsibilities. So the book does a nice job of lining out for us some of the differences between our roles previously as RNs versus what your role is going to be like as an APRN. As the RN at the bedside, you guys know that the RN functions as a patient advocate, that they can collaborate with the prescribers to improve the quality of care. We know as nurses ourselves that we can provide valuable insight because we're with the patient oftentimes for 12 hours, 3 days in a row. So we do have values and information to bring to the table. As APRNs, though, we now transition into that prescriber role. And so we have a higher level of responsibility related to our ability to use pharmacotherapeutics in making the decisions of what drug we're going to give and why. Oftentimes, it's very common for students to feel like one of the hardest transitions when they're coming into realizing they're about to be a nurse practitioner or CNS is realizing, oh my goodness, I have a lot of responsibility, a lot of choices I have to make that it's now on me. As an RN, I gave the medicines, but now as the APRN, it's my decision on whether or not those medicines are to be given. So you do have a transition in your role that is going to take a little bit used to, right? As an APRN, then you are going to have a more in-depth knowledge of pharmacotherapeutics to understand what drugs you give and why you give them. In 2010, the Institute of Medicine put out that publication that called for removing scope of practice barriers and to allow nurse practitioners to practice to the full extent of their education and training, and we have made great strides since then. CNSs also have made a great stride, but still CNSs are fairly limited in prescriptive authority. Some states do not allow CNSs to have prescriptive authority. All states have title protections for the APRNs, meaning we can use the words nurse practitioner. The Board of Nursing regulates practice in all but 5 states. This is a really important concept because I am a firm believer that we do not ever want to have nurse practitioners or any of the APRNs managed by the Board of Medicine. Because they don't understand what we do, and that is just not what we would want. So we are very lucky that in all but 5 states, it's the State Board of Nursing that determines and regulates APRNs. Your scope of practice is determined by your APRN license and what you're allowed to do state by state. The example your book talks about is that 2 states, for example, Georgia and Oklahoma, they do not allow nurse practitioners to prescribe Schedule II medications. Louisiana, as an example, will restrict Schedule II prescribing by NPs for only the obesity medicines or for chronic pain. South Carolina nurse practitioners must have Schedule II prescribing outlined specifically in their practice agreements. These are some of the examples that the book talks about too. Advanced knowledge. APRNs blend medical, pharmacology, and nursing knowledge all together. This is where we can actually really sell ourselves of why we're effective in our roles, because we bring holistic perspective. We are used to caring for the patient as a whole, mind, body, spirit. We are very comfortable with patient education. We can oftentimes build trust easily. We're good at communication, all of those things. And then as we go back for advanced knowledge, now we're also taking our advanced medical knowledge and pharmacology knowledge, and we're blending that in with our previous nursing experience. Additional knowledge, critical thinking, and assumption of a higher level of legal responsibility are required to become a prescriber. The knowledge of medicine and the pharmacology and nursing are all intermeshed and intertwined. As a prescriber, it becomes the role and responsibility of the nurse practitioner or the CNS to determine the diagnosis for which the drug will be prescribed, to prescribe the appropriate drug, to monitor for the expected outcomes of the drug, and then to incorporate a holistic assessment of the impact of disease and therapy on the patient's lives. In order to be a safe prescriber, you have to understand many different components, and you have to be able to tie them in all together and synthesize that information to make the best judgment of what you're going to do for your patient. So you have to have knowledge of pathophysiology and the disease process. You have to have your undergraduate pharmacology and your advanced pharmacology knowledge. You have to understand the rational drug selection for the disease process. You have to understand the appropriate diagnostic testing for drug monitoring, and you have to keep up with new drugs and medications. One of the coolest things about being in the medical field, I think, and in the nursing field, is that things are always changing. We're never going to get bored. There's always advancements. Things are constantly changing. But the downside is things are constantly changing. So we do have to pay attention to keeping up with new drugs and new medication alerts. Many state boards of nursing require certain amount of pharmacology CMEs to ensure that we're going out there and we're taking new courses and we're doing things to keep up on the changing landscape when it comes to medications. The benefits of having an APRN as a prescriber include that we can be really effective at lifestyle and chronic disease management for a variety of reasons. Oftentimes, again, we have great communication, and we can have we can develop a better therapeutic relationship with our patients maybe more quickly, or we're pretty good at it to get their buy-in. We tend to be, again, more holistic, and so oftentimes the nurse practitioners are more willing to consider herbal therapies. We understand the importance of nutrition counseling and the education of the patient. One of the things you're going to hear me say throughout the course is that as an APRN, you're caring for the whole patient, and you are prescribing, quote unquote, prescribing both pharmacological and non-pharmacological interventions. It is just as important to educate the patient on their heart failure, their diet, their exercise, their fluid restrictions, whatever. That is just as important as prescribing the right diuretic and educating them about the diuretic. Both of those factors are crucial in treating the patient holistically. And that is what we as APRNs tend to do very well, is tie that all together. So when you're thinking about what should I prescribe for my patient, I want you to start thinking about education and diet restrictions. For example, when you say eat less than 2 grams of sodium in a day, that is an order. That is a prescription that you are telling them to do, just the same as take your Lasix before 8 a.m. every day, right? These are things you are prescribing for the patient to do. We can also have good holistic approaches to care, mind, body, spirit. We tend to be more culturally sensitive and specific for the patient, and we understand that we how to tailor our education to the patient preferences. Clinical judgment in prescribing. The box in your book is box 1-1, and these are the questions to ask when you're prescribing. These are all important things to consider. You may read evidence-based practice. You may get on up to date. You may read standards of practice, say you give this drug first, then this drug, then this drug. But then you have to now learn the art of medicine in understanding, well, which drug, though, is best for my patient, and I need to make a judgment call on that. So I'm asking myself, is there a clear indication for it? What are the goals of this therapy? Is the drug going to meet the goals of the patient? Is the drug cost effective for the patient? Is it something that's on their formulary? Will their insurance cover it? So it doesn't matter that I look up in UpToDate that it says give this drug for this disease. I have to understand how that drug specifically plays into my scenario with my specific patient and make clinical judgments to make sure that we're choosing the right drug. Working as a nurse practitioner, you will be collaborating with other providers. It's going to be critical. I love that the book kind of goes into talking about physicians and the relationship with APRNs. Historically, it has been a bit of a roller coaster ride. I think they say that well in your book. We have had differences of opinions. There have been open kind of dissent among some of the physicians in the American Medical Association, having some concerns about nurse practitioners and their authority and how they practice in the hospital. So still at the political level, there's still some discord there. However, I would agree with your book when it says that really at the, the grassroots level, we don't tend to see as much conflict as we used to. 20 years ago in practice, I can tell you we had a lot more difficulty being an NP and kind of being looked down upon. A lot has changed in a few generations. A few graduating classes now. The way that the physicians are taught in school and how to work with APRNs is different. We're not as threatening, I don't think, is how I would probably say it, because the new residents are used to working with us. They see us through med school. They see us in their residency. It was harder back in the day when you'd been a physician for 20 years and you're set in your ways, and now all of a sudden you have this, well, what is this NP that's been thrust upon me? But slowly over time, as we've become more present in the medical field, and now we're here to stay, the younger physicians that are coming out of practice, they're used to working with us, and we tend to have much more collegial roles at the grassroots level in the day-to-day workings. But still, at the bigger level in some of the political arenas, there can still be some discord. At the end of the day, physicians working with nurse practitioners or APRNs, we tend to work very well with each other. We tend to be allies and kind of yin and the yang, and can be a very effective pairing. There could be different perspectives on prescribing. Oftentimes, physicians are a great ally to have when you're talking about making decisions. They have a lot more biochemistry, a lot more in-depth training in some areas in their medical school than we do. You're going to collaborate also with people like pharmacists. They may be your new best friend. The PharmD now is a clinical practice doctorate. Now you're going to see, and you probably have already seen this in your facilities here in Sioux Falls. We are putting pharmacists in specific locations, and they are the clinical expert in that area. There's one in the ER, there's one in ICU, there's one in long-term cares. When not that long ago, we had to go to the ER for my son who had a dislocated elbow, and they needed to do conscious sedation in the ER. The pharmacist, even though it was after hours, pharmacist was in the ER, came right up to the bedside and started drawing up drugs and calculating doses. The clinical pharmacists are right there with us now, and you will be collaborating with them. And they are the experts in the pharmacokinetics and pharmacotherapeutics. You're also going to be having other people that are specialists in their areas. The diabetic educators, the wound care people, the physical therapists. You're going to encounter all sorts of disciplines that we have to work with because they have insight into what is the inner workings of our patients, and they have valuable information to share. Their feedback and their insights very important. There is some difference when you look globally at nurse practitioners that are different than how we function in the United States. This screen here is talking about the role of the APRN in Canada. It's a little bit different than in America, and I'll let you read through that in your book. It is worth spending time talking about facilitating positive prescribing outcomes. this is an area where, again, I say we market ourselves, and that we can kind of brag about, maybe is even the way to say it. Oftentimes, we can do a good job as APRNs because of our nursing background in obtaining positive prescribing outcomes. It doesn't do us any good to prescribe farm or non-farm interventions for our patient if they are not going to do them. So how do we do that? How do we break down the barriers to getting the patients the interventions and the drugs that they need? How do we have their buy-in? Well, there's a couple different things. One, we can always have effective communication. But one of the things that the book talks quite a bit about is just this idea of adherence. So let's go through some of these things in a little bit more detail. It's really important to talk about. When they are thinking and we're talking about adherence, what are we saying? We're saying to get the patient to do what we ask of them, to take the drug, in this case, when we're talking pharmacology. We understand that prescribing is not a one-sided role, right? It takes two to tango. We can lead the horse to water, but they have to drink. Patients also have to do their part in getting to the outcomes that we are all looking for. The problem of poor adherence to drug therapy is widespread around the world. The FDA estimates that 30 to 50% of patients adhere to their drug programs. That's it. Non-adherence costs $100 to $300 billion in direct health care in the United States alone. The CDC found that 30% of new prescriptions are not ever even filled. Chronic disease patients are likely or more likely to have spotty adherence. People that are chronically sick and tired are sick and tired of being sick and tired. They don't want to take their medicines. They're kind of done with it all. Those at high risk for poor adherence include patients who have asymptomatic conditions. If you tell me I have blood pressure but I feel fine and you want me to take these 3 pills every morning, forget you. I don't even feel bad, right? People with cognitive impairment. It doesn't do any good for a demented gentleman to be in the office and I spend an hour explaining to him why he's taking what drugs and how to take them when he's not going to remember it tomorrow. You know, his daughter waits in the waiting room and she's his caregiver. Well, we have to go bring the daughter in. Those kind of things. One of the things that can be really scary is when we think about mortality rates double for cardiovascular and diabetic patients who do not follow their treatment plan. I mean, we can honestly say to those cohorts of patients, guys, if you don't follow these regimens, your mortality rates double. Intentional versus non-intentional adherence is spoken of in the book. Again, that's pretty straightforward. Psychiatric illness is another one. Sometimes people have a break from reality, or people are, if you're bipolar and you're manic, you feel so good. Why would I want to take a medicine to bring me down? Or I feel so good, I'm so focused on my feeling good that I don't go take my medicines. Oftentimes people with schizophrenia, once they are feeling well, they don't want to take their medicines anymore. There's a lot of reasons that could come into play of poor adherence. So how do we break down the barriers to adherence? You know, we have to know what is in the way. So limited access to healthcare, adverse drug reactions, polypharmacy, sensory or mobility challenges, pediatric patients, and fiscal issues. Okay, obviously limited access to care is going to be a big thing. If I give somebody a drug called warfarin and I say, you need to go to the clinic every 14 days and check your INR, and they can't afford to get to the clinic. They don't have a car. They don't have a bus pass. They can't even get there. Obviously, we're probably not on the right plan and they're not going to adhere to it. If I say, hey, take this drug, it's called metformin, it works really well. And sometimes it gives people a little bit of stomach upset. And that drug causes that patient rip, snort, and diarrhea. They're not going to take it, right? That adverse drug reaction is simply, it's not worth it. They'd rather have a high blood sugar than having stomach cramps and gas and diarrhea. when we give someone complex drug regimens. Well, here's an example. You try to give Keflex to somebody or some of these drugs that we want to prescribe 4 times a day. Nobody's going to do well on a QID medication regimen, right? There's just not, we're human. It's not going to go well. One of the things I think about with mobility challenges, I had a patient that this happened to, where their daughter only worked part-time. So she'd get up in the morning and she'd give mom her morning doses of medicines and give her morning diuretics. Mom had really bad knees and it was really hard for her to get out of the seated position. So the daughter would be there to help kind of heave her up to get her walking to the potty and then heave her up off the potty to walk back to her chair. That was kind of the help that she needed because of her bad knees. And then at lunchtime, the daughter went to work till the evening time. And then the patient kept coming in heart failure. Well, what was turning out was that the patient wasn't taking her afternoon diuretic dose because she couldn't get up and down to the toilet. And she was tired of having to wear Depends on wet in her Depends, so she just stopped taking her afternoon dosing. Okay. Fiscal issues. I can tell you that I have drug XYZ. It's the miracle drug. It's going to cure you. It has no side effects, and you're going to feel like $1 million. But if it costs $2,800 a month, nobody's going to do that, right? So these are some of the barriers you will see to practice. So how do we improve that? How do we improve and get over these barriers? I said it in the beginning, clear communication. Oftentimes you will excel in this area when we compare ourselves to others. We can typically do a really good job. We've learned how to therapeutically communicate with our patients, and we understand how to give patient education, and that goes a really long way. I am amazed when I go to other doctor's appointments or provider appointments with family members or what have you, and people will be like, I'm going to give you this drug. It's called XYZ. You take it twice a day, okay? Now, if you have any troubles, please let me know. And again, we'll probably see you again in 6 months. And don't forget to stop in and make that appointment on your way out. Out they go. And you're left, and they look at me and go, what, why am I taking this? Zero education about it. And that just doesn't work. You need to say, hey, you have this condition. I'm worried about that. If we don't treat that condition, these are the things that could happen. And even though you feel okay right now, I'm looking big picture for you. If we get on top of this now, trust me, in 10 years, you will be grateful that you have done this part. And one of those is taking this medication. Let's think about something like triglycerides or high cholesterol, what have you. If you say to them, I know you don't feel bad, but I'm telling you, this number's of concern, okay? And even though, yes, maybe you're only in your late 40s and you're still pretty active, this is the problem. I'm looking big picture for you. The difference between whether or not we decide to control this now or we let it go uncontrolled for 20 years might be the difference between whether or not you have a devastating heart attack or stroke. So yeah, I know it doesn't seem like it's a big deal to take it now, but trust me, it is. Right? So this is the medicine. You're taking it because you do have high cholesterol. Okay? Some people call this drug a statin. Now, please be cautious when you're Googling statins. There's so much misinformation out there. They got a really bad rap in the media a long time ago, and it has just stuck. Yes. Can they cause some myopathy? Yes. But it's actually not that common. Those kind of conversations that to have with patients just go a super long way. Because if you take the time to explain it, to talk about it, to answer their questions, they are going to be much more willing to do it. Okay? There are drugs we give like an SSRI. I say to patients, unfortunately, these are the kind of drugs that have to build up in your system. Once we get you to a good level on the right drug, they are very effective. However, for some people, we have to find the right one that works for you. I'm going to start you on sertraline. I think it's going to be a good choice for you. But again, we have to be patient and give it some time to build up. So I'm going to give it to you. I need you to do a good solid 8 weeks on this medicine before we can really know whether or not it's going to work. This isn't a medicine that you're going to all of a sudden feel better after 3 days. You got to be patient. Then I'll say things like, sometimes, unfortunately, for some people in that first week or two, they can get a little queasy on these medicines. But by far and away, it goes away. Most people will do just fine after the first or second week. So you gotta give it a fair shake, okay? Because these can be really effective medications for people. You just gotta get past that first hump. Okay? So if you take it and it does make you feel an hour or two after taking it maybe a little queasy, well, try to take it with food. Or some people take it right before bed, and that works really well for them. They don't have any side effects, right? You talk that through with them and you explain it. And even though it can be time consuming to do that, those are the ways you're going to get good adherence. We want to use drugs that you only have to take once a day or twice a day. That's going to be much more successful for a human being to remember to take accurately than something that's more complex. Remember, the caregiver role is important. If you're doing younger children, if you're trying to give a drug to a 14-year-old, you gotta tell them about the side effects to them and to their parents. If they have cognitive issues and older adult or elderly patients, you have to talk to their caregivers. Now we are lucky we have a lot of technology that can act as cues, as reminders. We have our phones and our watches that we all carry around. Work with your patients to strategize. How is this going to work? Some people say put it in their medicine by their toothpaste and toothbrush so they see it every night. Talk about strategies for success. Also, don't forget the power of follow-up visits. Okay? I'm going to schedule an appointment for you in 8 weeks. I want to see you again. So it gives us an opportunity to talk about it. Because maybe you're experiencing something that I could make better with adjustments. So I think it's worth it. Even if you think we're doing okay, why don't you come on in and let's just have that visit, okay? If you don't think you can take it to the 8 weeks because you just don't think you can tolerate it, give me a call. We'll get you in sooner and we'll figure this out. That's going to go a long way to improve your adherence. This talks about how do we measure adherence. Yes, we can have you either took your medicine or you didn't, right? But adherence means we also need to make sure that patients are getting the effect that is good for them that they need. We want them to feel better because they take the medicine. Now, again, we said that's hard for, asymptomatic conditions, but for other conditions, we want them to feel better. We want them to get the good effect of that medicine. We know that the predictors of adherence can include the patient's definition of quality of life, what their comorbidities are, their beliefs, their culture, their backgrounds, their social support, their education, their literacy, their knowledge. All of those things can affect whether or not we're going to have the adherence we need. So to summarize, we want to make sure that we understand as we launch into this course what your role is, what the responsibilities of you as a prescriber. Really, I would just say you have to remember, as a prescriber, the buck stops here. Okay? At the end of the day, when that prescription is under your name, the sole responsibility for it is yours. So we take prescriptive authority incredibly serious. It is of a great responsibility because it's a great power. Use your resources and use your interdisciplinary teams. Listen to the input of those around you and bring the experts in and their opinions. You can help facilitate. You can be the biggest impact, you yourself, on how you treat your patients and what you choose to do. You will be a huge driving force for good or for bad when it comes to positive prescription or positive prescribing outcomes. So we have these lovely little knowledge checks, which is really nice throughout the PowerPoints. Which of the following is the best strategy to enhance medication adherence? A, provide written education. B, explain in detail how the drug works. C, communicate clearly at the 6th grade level. Or D, tell the patients to take the drug as prescribed. And this answer exists within your book, and the correct answer is C. they say, a good rule of thumb, is that if you explain things at what is considered to be a 6th grade level, you should be sufficient. So we want simple language and highlighting the critical points. And so please reference the table 1.2. Barriers to medication adherence include which of the following? A, real or perceived adverse reactions. B, trust in the provider. C, remembering to take the medication. Or D, belief in the effectiveness of the medication. So which of these barriers to medication adherence include what? The answer here is A. Real or perceived adverse outcomes of reactions will directly affect the outcomes of the prescribed drug regimen. So that wraps up Chapter 1. Thank you for hanging in there. We'll meet you in Chapter 2.